Hello everyone. I am Dr. Manaswi Gupta, consultant physician practicing in Hisar, Haryana. So today we will be discussing about promising CKD perspectives of SGLT2 inhibitors and DPP4 inhibitors. Diabetes is a strong risk factor not only for CVD but also for the development of CKD, which further worsens the occurrence of cardiovascular risk in diabetic patients. Approximately 40% of patients with diabetes upon screening of decreased eGFR and albuminuria have evidence of CKD. Because of the unique mechanism of action, SGLT2 inhibitor have a range of effects that may translate to potential benefits beyond glycemic control, especially in diabetic kidney diseases patients. Its associated pleiotropic effects, including reductions in blood glucose concentrations, natriuresis, and decrease in blood pressure and body weight changes, might confer protective effects on the kidney by reducing CV and renal risk factors in diabetes. So, EMPA-REG outcome was a randomized, double-blind, placebo-controlled phase 3 trial study involving 7,020 people with type 2 DM, almost all with established CVD. The mean eGFR at the baseline was 74.1 ml, and the median UACR was 18 mg per gram. Pre-specified renal outcomes in this study included incident of or worsening nephropathy, defined as progression to macroalbuminuria, doubling of serum creatinine associated with eGFR. A main driver for the reduction in nephropathy with empagliflozin was a slower progression to macroalbuminuria. Compared with placebo, empagliflozin was also associated with significant improvements in a post-hoc composite endpoint of incident or worsening nephropathy or CVD, progression to macroalbuminuria, and initiation of RRT, with no differences reported between the two therapeutic doses. In a sub-analysis from EMPA-REG study, empagliflozin decreased new onset or worsening of nephropathy by 39% on the top of a RAS blocker therapy. The addition of empagliflozin was associated with slower progression of kidney disease. The CV and renal benefits seem to be maintained independent of eGFR level, even with progressive eGFR decline. A study of patients with type 2 DM and CKD showed that the addition of empagliflozin was associated with a reduction in albuminuria over 52 weeks. At the end of treatment, more patients improved from macroalbuminuria at baseline to microalbuminuria or from microalbuminuria to no albuminuria. In EMPA group, that is 32.6% empagliflozin 25 mg versus 8.6 and 27.5% with empagliflozin 25 mg versus 21.4%. Transient decline in eGFR after introduction of SGLT2 inhibitor was shown to be reduced with chronic maintenance treatment. This pattern was consistent across range of eGFR values. SGLT2 inhibition may produce renoprotective effects due to a reduction in intraglomerular pressure mediated by empagliflozin and associated with a reduction in renal hyperfiltration, a potential risk factor for renal disease progression in diabetes. SGLT2 inhibitors might offer synergistic effects with other blood pressure lowering agents or diuretics in patients with diabetes and CKD. The inhibition of SGLT2 leads to tubule glomerular feedback via enhanced natriuresis and delivery of sodium to the macula densa, thereby decreasing diabetic glomerular hyperfiltration due to hyperglycemia. This is hypothesized to reduce the resulting chronic kidney damage. Ketone bodies are a more energy efficient fuel in renal tubular cells than glucose, and as a result, renal oxygen consumption is reduced in the presence of mild ketosis. Hence, it has been suggested that the use of ketone bodies as energy substrates in patients receiving SGLT2 inhibitors may contribute to the renoprotective effects of these agents, with a similar mechanism as in the mitochondria. The management guidelines from the American Diabetes Association recommend that SGLT2 inhibitors should be considered for patients with diabetes and CKD who require add-on therapy to metformin on the basis of recent CVOTs, indicating that these agents may reduce the risk of CKD progression and CVD outcomes. DPP4 inhibitors reportedly ameliorated renal function and pathology in DKD. Linagliptin decreased podocyte apoptosis, one feature of diabetic kidney disease pathology, by enhancing insulin signaling. Carmelina study, which is a linagliptin CV outcome study, confirmed that linagliptin reduced the progression of albuminuria by 14%, reduced risk for progression of albuminuria. Moreover, linagliptin demonstrated CV safety, including in patients with advanced CKD. Linagliptin slowed progression of albuminuria without affecting eGFR slope or other kidney outcomes. Linagliptin has a unique profile with primarily non-renal but hepatobiliary route of elimination, requiring no dose adjustment in patients with CKD. Carmelina study, which is a linagliptin CV outcome study, confirmed that linagliptin reduced the progression of albuminuria by 14% and reduced risk of progression of albuminuria. Empagliflozin and linagliptin is now recommended for use in patients with eGFR upon up to 30 ml per minute as per the latest prescribing information. A large clinical outcomes trial investigating empagliflozin for heart and kidney protection in patients with CKD with or without diabetes. EMPA-Kidney is underway with plans to enroll approximately 6,000 people, including those with or without albuminuria. The results of these studies will help to further define the role of new treatment therapies in the management of patients with CKD, including the effects of cardiovascular disease and premature death. Thank you.